the Armstrong Institute for Patient Safety and Quality, both at Johns Hopkins. From a clinical perspective, he is an attending physician in the Medical Intensive Care Unit at Johns Hopkins Hospital and the Medical Director of Johns Hopkins Critical Care, Physical Medicine and Rehabilitation Program. Dr. Needham received his MD degree from McMaster University in Hamilton in Canada and completed both his residency in internal medicine and his fellowship in critical care medicine at the University of Toronto. He obtained his medical training. He completed bachelor and master degrees in accounting and practiced in a large international accounting firm with a focus in the healthcare field. Dr. Needham is principal investigator on a number of NIH research grants and has authored more than 350 publications. His research interests include evaluating and improving ICU patients' long-term physical, cognitive, mental health outcomes, including research in the areas of sedation, delirium, early physical rehabilitation, and knowledge translation and quality improvement. So I'm sure you'd all agree that he has a lot to offer us today. So thank you, Dale.
Thank you so much. Great. So I'm very happy to start off today's conference, and I'm so happy to see all of you in the audience and people that are online. Thank you so much. I want to talk about the rationale and the evidence for rehabilitation in the ICU. I do have a disclosure. I'm principal investigator on an NIH-funded randomized trial looking at the combination of protein supplementation and early exercise. As part of that, 2 companies have provided some support, but that won't influence today's presentation. So I want to cover 2 things. I want to give a brief historical background and rationale for why this is so important, why ICU rehabilitation is so important. And then I want to give a brief overview and update on the evidence for ICU rehabilitation. So I'm going to take us back to a godfather in the United States of critical care medicine. Dr. Tom Petty was around when his intensive care unit was first created. And he reminds us that when his ICU was first created in 1964, mechanically ventilated patients were routinely awake, alert, sitting out of bed in a chair. He contrasts that with modern critical care, where our patients are often deeply sedated, paralyzed, lying without motion, appearing to be dead, except for the monitors that tell us otherwise. And that modern approach to critical care results in patients losing muscle mass and strength and having many long-term negative consequences. So Dr. Petty was teaching us that decades ago. And the concept of early rehabilitation is not new. This is located just several hundred kilometers from my hospital, where in the 1970s, one of the hospitals was routinely mobilizing their mechanically ventilated patients and reminding us that early ambulation was clinically useful, patients' acceptance was great, weaning from the ventilator was hastened, and prolonged bed rest was minimized. So this is not a new concept, but we need to take our modern critical care and move back to the start of ICU for our patients to be awake and moving. So why should we be interested in physical medicine and rehabilitation, especially for the ICU doctors and nurses? Why do we need to partner with our PTs, our OTs, and our speech language therapists? So 2 famous Canadian neurologists who specialize in critical care describe this. They say people like me, ICU doctors, when we are focusing on many complex issues, we focus on the heart, the lungs, and the kidneys, and we often forget about the brain, the nerves, and the muscles. those complications get overlooked. And as a result, when a patient leaves the ICU, then we realize they're very weak. They can't do their activities of daily living. They have impaired cognition, and they need prolonged rehabilitation. That's because ICU doctors and nurses are not focusing on the nervous system complications when patients come to the ICU with a medical or surgical problem. We need to keep thinking about the brain, the nerves, and the muscles, and we must partner with our rehabilitation experts. So landmark work from the University of Toronto, where I trained, helped us understand the long-term complications after critical illness. We know from this study that on average, patients lose 18% of their body weight in the ICU. This can take up to 1 year to recover. That's mostly a loss of muscle mass. Unfortunately, we're not losing fat when we go to the ICU. And as a result, a year later, patients' 6-minute walk distance is only 2/3 of predicted. And only 50% of patients are returning to work 1 year later. They spend 1 or 2 weeks in the ICU, and they have problems for years afterwards. And this really affects the entire family when the primary employed person cannot return to work. This study demonstrated that 1 year later, patients are universally endorsing muscle wasting and weakness, contributing to their bad outcomes. So how does critical illness contribute to these bad outcomes? We know that there's critical illness neuromyopathy, but I want to focus on bed rest. We understand that in healthy, well-nourished patients, that bed rest alone can lose 4 to 5% of muscle strength. Imagine if you're critically ill, how much more severe this can be. So this landmark study looked at mechanically ventilated patients to characterize skeletal muscle wasting using ultrasound, histology, and biochemical analyses of protein balance. The study demonstrated in patients with mechanical ventilation plus at least one additional organ failure that within 1 week, patients lost 16% of their muscle cross-sectional area, with 9% lost within the first 3 days. So we cannot defer rehabilitation until patients are out of the ICU or until 1 or 2 weeks later. There will be a lot of muscle loss that happens early. We also know that those were ultrasound findings. We know from muscle biopsy findings that the cross-sectional area decreases by about 10%, and 50% of biopsies have evidence of necrosis. And the biochemical analyses show us that over the first 7 days, protein breakdown increases and protein synthesis decreases, so there's net catabolism happening that leads to this muscle loss. So no matter whether it's studied with ultrasound, biopsy, or biochemical analyses, there's early and rapid muscle wasting during the first week in the ICU. So this is why ICU doctors and nurses need to be thinking about muscle recovery. That study did not look at muscle strength or physical functioning, it looked at muscle wasting. So I'm going to refer you to a study that I did at 13 ICUs at 4 hospitals in Baltimore, where we followed patients for 5 years after their critical illness. What I'm going to present today was a study from the first 2 years where we evaluated patients at 3, 6, 12, and 24 months. All of these patients had ARDS and survived their hospitalization. All 4 of these figures show patients with ICU-acquired muscle weakness in the dotted line and patients without weakness in the solid line. The top left shows us that patients with weak arms and legs also have weak grip strength. That makes sense. 2 different measures of weakness. The bottom left shows us that they also have weak respiratory muscles. And the 2 figures on the right is the first study that demonstrates this weakness is associated with impairment in physical functioning. The bottom figure looks at the 6-minute walk distance. The top figure looks at self-reported physical functioning. And we can't do a 6-minute walk distance before you get critically ill, but we can ask people to recall their physical functioning before they're critically ill. And what we see here is that patients that had ICU-acquired weakness did not have perfect physical functioning before their ICU stay. It was maybe 85%, but 3 months later, their physical functioning was only about 15% of predicted. Went from 85% to 15% and stayed low 2 years later. So this muscle weakness is profoundly important for patients' quality of life and physical functioning. We did an analysis looking at what variables were associated with this muscle weakness. And all of these variables on the bottom half of the table we thought might be associated with muscle weakness, but they were not. But once we considered all of those variables, we found that there were 2 things that were significantly associated with muscle weakness out to 2 years after patients' ICU stay. The first is age. That's not a surprise. Older patients are more vulnerable to muscle weakness. That's not a modifiable risk factor. But the second variable is, for each additional day of bed rest in the ICU, after considering all of these other variables, each additional day was associated with muscle weakness all the way out to 2 years after the ICU stay. So each day that we provide an excuse for why we can't engage patients in rehabilitation may infect them 2 years later. So we need that close partnership and collaboration to improve our patients' long-term outcomes. So now I'll transition. What's the evidence to support rehabilitation? I've just presented the rationale, but are there randomized controlled trials? But the first question we need to ask, is this safe? Most ICU doctors and nurses are not used to having rehabilitation people in the ICU. They think it's not safe. So this is landmark work that we did years ago where we summarized every study that evaluated the safety of ICU rehabilitation. There were 22,000 rehabilitation sessions across almost 50 publications. And we had a very liberal definition of a safety event. And with that, it was only 2.6% of sessions that had any type of potential safety event. But when we looked at safety events that actually had a consequence, safety events that might matter, it was only 6 events in every 1,000 physical therapy sessions. So this can be safe with collaborations of ICU doctors and nurses along with rehabilitation clinicians. And more recently, there's a second meta-analysis with updated data look at the safety of rehabilitation. This study had 67 randomized trials that compared early rehabilitation to a control group. They found about 3% of sessions had a potential safety event. But when they did a meta-analysis, there was no increased risk of death and no increased risk of safety events for patients in the early rehabilitation group compared to the control group. So there was no harm of increased rehabilitation in these randomized trials. So it's safe if we have teamwork and communication. But is it beneficial? Can we get these sick muscles to have less impairment? So I'm going to present a couple of meta-analyses. I really like this meta-analysis that has about 5,000 patients and 60 trials, because they specifically looked at patients that got early rehabilitation compared to control groups that got lower rehabilitation. So the control groups here got less than 5 rehabilitation sessions per week, which is still a lot of rehabilitation for most ICUs. And they found that patients that got early rehabilitation had shorter mechanical ventilation duration, ICU length of stay, and may have had better physical functioning. And the greatest benefit came from active functional mobility rather than more passive interventions. So really the skill of our therapists and nurses getting patients moving rather than laying in bed with more passive interventions. And there's an even more updated meta-analysis with 58 randomized trials, again showing us very recently there is no negative effect of early rehabilitation, and again showing us that this decreases mechanical ventilation and ICU length of stay for those patients that are getting functional mobility. And this meta-analysis shows as more and more studies are being published, the results are becoming more and more consistent. But we need more data to understand the effects on the brain with cognition and the effects on function, because that's what's really going to matter to patients. I talked about the brain just a minute ago. Can doing early physical rehabilitation to patients' arms and legs affect their brain? Well, this meta-analysis specifically looked at that question. And this meta-analysis demonstrated that early rehabilitation can reduce the odds of delirium or confused thinking in the ICU by about 50%. So having mobility of patients can improve patients' brains. Mobility can also reduce the duration of delirium by about 2 days. And what I always remind people is the head bone is connected to the body bone. What we're doing with patients' arms and legs when they're critically ill affects their thinking. And as their thinking gets more clear, then they can participate even better with our therapists and nurses. So these are a few examples from my own ICU. This patient that had a tracheostomy was so tired of laying in bed in the ICU, we got him outside of the ICU into our courtyard for a high-level functional mobility. He's sitting on a balance ball. He's doing upper extremity strengthening with an OT assistant, a physical therapist, and a respiratory therapist. That teamwork that was necessary to get him out of the ICU with the sun shining on his face. This man now had a reason to live. He was so depressed when he was staying in his dark, small ICU room. This is one of our very, very early patients who was awake, alert, with an oral endotracheal tube, out of bed, writing notes to communicate, awake and alert, no midazolam, no propofol, no neuromuscular blocker. This man was very, very sick, but he is awake, alert, out of bed. This is interactive video games. We call this WeHab. this young woman was awake and alert and boxing, while her mother at the sidelines was cheering her on, telling her to punch harder and harder. So she had balance, she had upper extremity function, and our hospital administrators told us this is likely the least expensive piece of equipment that we've ever asked for in the ICU. A Nintendo Wii is so much less expensive than a ventilator. This is a tilt bed that allows patients to have passive weight bearing. This man was so weak he could not even attempt to stand. We have many, many videos and we have patient testimonials talking about the experience at our website. I also want to touch on how do you actually implement this at the bedside. So the green part of this figure talks about the culture change process that we need at the ICU and the hospital level. And then the blue part talks about what we need to do with every single ICU patient, what the therapist and the nurses need to think about before they engage in rehabilitation. So this is a great practical resource. So I'm going to conclude and remind us then that early mobilization is exciting and dynamic. It has a historical basis. It's safe. There's evolving evidence for benefit. But we need to carefully think about which patients will benefit the most. We don't yet know which types of rehabilitation are most beneficial. We don't know the optimal dose. We don't know the optimal frequency, duration, and intensity of each session. We need to be thinking about sedation. It has a profound effect on rehabilitation. And we need to always be measuring if our interventions are helping patients. For people that want more information, this is my group's website. I have a monthly email list that goes to maybe 4,000 people from around the world that gives the latest updates on rehabilitation, delirium, long-term outcomes. You're welcome to join that. It's very, very simple. It's nothing fancy like what we've got here. This is just a simple email with a bunch of links to publications and educational resources, including my advertisement about today's conference. People also say to us, Dr. Needham, how do you do these things at Johns Hopkins? So we tried to put these resources at this website with that little bit.ly link that's ICU Rehab SOL. So many free resources can be downloaded from there. Our sedation protocol, our safety criteria, what we use every day in my ICU is available there for free. And then there's the ICU Rehab Network. We're going to learn best if we have networks and international collaborations. And that's why we created the Asia-Pacific Mobilization Network, as shown there. We need to come together to learn together, to network, and to grow. And if you happen to be on Twitter or X, and you want a daily update on ICU Rehab, you can follow us on Twitter as well. And for people that can travel to Baltimore, every year we spend 2 or 3 days full-time talking about ICU Rehab at our International ICU Rehab Conference that happens in November this year. So I invite anyone that can make the trip to join us in Baltimore. And with that, I'm very thankful for your attention, and we'll look forward to the question and answer later on. Thank you so much.
Thank you very much, Dale. We will have questions after the two presentations, so Dale can have a break, and it gives me great pleasure to invite our next speaker, Min Nguyen, who is very familiar to, I think, probably everybody in this room through his clinical expertise, his teaching expertise, as well as his coordination of this meeting. So Min achieved his bachelor diploma in physiotherapy at the University of Medicine and Pharmacy at Ho Chi Minh City in 2013. He achieved his master's degree in cardiovascular health and rehabilitation at the University of Chester in the UK, having achieved the Chevening Scholarship. He has a master's degree in physiotherapy for respiratory at the University Catholique in Leuven in Belgium, for which he also received an ARI scholarship, and he's a doctoral student at the University of Catholique in Leuven as well. He's a lecturer of the Rehabilitation Technique Department, teaching subjects in cardiovascular and pulmonary physiotherapy for adults and children, and physiotherapy for non-communicable diseases and critical care. He's also the head of international affairs at the Vietnam Physical Therapy Association, and his current position is the lecturer of the Rehabilitation Department at the University of Medicine and Pharmacy in Ho Chi Minh City. Welcome, Min.
Yes. Thank you so much. Thank you so much, Sue, for your nice introduction. Dear all colleagues, my pleasure here today to share my topic. My topic is relating to the rehabilitation in the ICU in Vietnam, reality, challenges. I don't think that I have solution for you, but I think I have some suggestion for you. And when I mentioned about the rehabilitation in my presentation, I focus on the physiotherapy, occupational therapy, and speech therapy. I hope that my presentation will can illustrate some aspect of rehab practice in Vietnam, and therefore we can have an opportunity to reflect on our practice for the improvement. So with the presentation of Professor Del Nidam, I believe that I don't need to clarify again the benefit of the rehabilitation in ICU. In my presentation, I try to demonstrate the current practice in ICU in Vietnam. So I used the Google Trend, and with the internet accessibility rate of more than 80%, I believe this is a very reliable tools. I have to say that I don't receive money from Google to advertise this, but you can see that the blue one is the number of searches for intensive care, and the orange one is the rehabilitation for intensive care unit, and you can see the huge gap between those. So what's wrong? What's wrong with us? So I am looking for data, and I conduct a small survey of the rehab practice in Vietnam. And so see, first, let's talking about the occupational therapy in ICU in Vietnam. Our data provided by the Occupational Therapy Network in Vietnam, representative for the OT in Vietnam. So only 2 universities have training program in Vietnam, and with 42 official graduate OTs and 36 in the south and 36 in the north, and in the central area we haven't yet have the training program for the OT in Vietnam. And with the population of more than 100 million people, this is a very small number, and we can see the huge unbalanced scale between the demand and the supplies. The education is not for the practice. The OT has not yet been implemented in the ICU setting, and considering about the functional activities of the patient, I believe that we haven't yet to utilize the very important role of the OT in the ICU setting. And for the education, we haven't yet has a good curriculum for the OT practice in ICU. And for the policy, the role and the responsibility of the OT, occupational therapy, in the ICU setting are not well defined. In fact, I found it hard to explain to some health professional what OT does in ICU. So without the legal framework and without the awareness of all the health professional, practice, OT practice in ICU can be very restricted. And how about the speech therapy in Vietnam? It's better, a little bit better, but the number of the human resources still very, very low. The practice in ICU is get better because we have some techniques that allow to use in ICU like swallowing or oral hygiene. But one of the thing that I believe that we didn't utilize the role of the ST in the ICU, that's the communication. We I believe that communication between the health staff and the patient is very important. Without them, we cannot give them the best intervention. And in ICU, I believe that we didn't utilize the role of the ST in the ICU, tried as a bridge to connect the patient and the health staff. And the policy is aware, yes, but the number of the techniques that's allowed to be used in the healthcare system to very limited. I believe that because it's a new one, new professional one. So in the future, maybe time can help to improve the situation. So as a BT physio, I concern more about physio. So I conduct a quick survey to investigate how the physio practice in the ICU setting. Honestly, I don't believe that my survey is well designed enough to be considered as a piece of evidence. However, I think that it can illustrate a general picture of how physio practice in ICU. And I asked 24 PTs, physio, 6 simple questions, include what is the main concerns in the ICU. As a physio, when you're thinking about a patient in ICU, what are you thinking? What assessment do you use and why you use it? What intervention do you provide to your patient and why you do that? Do you understand the mechanism behind that? Have you ever tried to mobilize the patient with or without a ventilator? And any barriers in your practice? And do you have any suggestion? And let's see the result. So I demonstrate my result in a purple. The sign of the purple demonstrate the number of the answer I received. So you can see that when thinking about the patient in ICU, we think about the secretion. Most of the answer I received is secretion. Secretion is very important. And joint stiffness and muscle and pressure ulcer because of long time lying down. And you can see that here, a very, very small purple, thinking about the ventilator, winning. And no one mentioned about the ICU archive quickness. Although you can see on the right side, we have a lot of evidence to show that the ICU acquired quickness can impair the mortality and functional not only during the ICU stay, but also after the ICU discharge. And physio can significantly prevent and reduce the ICU acquired quickness consequences. But we didn't care about that, so maybe we missed many opportunities to get the patient better. So, and how about the assessment? The assessment is most of the answer is they checking the medical record routinely, vital sign. Yes, for lung sound, for the general observation, they care about the pressure ulcer, and we can say okay, that's because we care about what our mention is about the pressure ulcer, and in assessment we're looking for that, so that is match. But if you remember, the most concerns is secretion. But here in our research, our survey, very few physio use the lung sound to assess the secretion. You know, we care about that, but we don't have the tool to measure that. So that's the case. No, very few mention about the Glasgow Coma scale. Muscle tone, no concern about the muscle atrophy induced by sedation, no mention about the ICF, muscle strength testing, cognitive sensation, functional activities or reflex. In other words, I believe that we don't have the standard assessment for the physio in the ICU, and we should think about that. Interestingly, if you connect this slide with another, the reverse slide, we see that the joint stiffness and muscle wasting is their concern. But in our survey, we didn't see any response about the muscle strength testing and range of motion assessment. That's our concern, but we don't assess it. That makes no sense. And if you compare with the on the right side of the screen, you can see that that is the minimal list of assessment that the physio should be used in the ICU. And I believe that there's a huge gap, not only in the number, but maybe also in the way we use it to clinical reasoning. Yeah, so a long way to go, I think. And how about for the intervention? Yeah, it depends on the region. Moving to the north, we have the percussion, vibration, and passive movement. Moving to the north, the physio use more chest compression and passive movement again. Yeah, so very, very few physio can explain why they use it. And very few mention about the echo pressure point for the chest therapy or the oscillation mechanism for of the cilia for the percussion and vibration. And and you can see that here we have a very, very, very tiny, teeny, small active exercise purple. So that means that the active exercise haven't yet been utilized in the ICU. Very, very few. And that's interesting because muscle wasting is one of our main concern. We have the best and the very cheap intervention, but we didn't use it. So we have to thinking about that. And look at on the right side, you can see that's the techniques. The minimal list of the physio techniques should be used in the ICU. But it look like in Vietnam, the number of choice for the BT physio in ICU is very limited. Yeah, and you can see that we know the problems, but we haven't yet assessed and intervene appropriately. So that's the thing we should consider, we should think about. Yeah. And how about the early mobilization? I have to say that is rarely applied in my survey. The physio say that they never try to mobilize the patient with the ventilator because due to the high risk, they're afraid of that. And evenly, the positioning was not always implemented. And our survey reported the number of the positioning a day less than the current recommendations. And the BT also say that they're afraid of the too sick condition of the patient, which prevent them from moving the patient. And some physio say that sometimes they are asked not to move the patient by all the professionals, health staff. So that's it. We need to talk to each other more, to understand to each other more. And you know, and here is for the cardiac patient, but I believe that we can use it in the ICU. So you can see here, if we have the patient who is very, very ill, and you do the exercise, the benefit you get it will be very huge. But if you get better, and you do the same amount of exercise, maybe the benefit is not huge as before. So, and the patient in ICU, I believe that they are too sick patient. So maybe the active exercise can benefit them the most. And we have to thinking about that. We should move them because they are very ill. Not we shouldn't move them because they are very ill. Yes. And the barriers, that's a maybe more positive side, slide, because we have the same barriers in Vietnam, the same barriers in Western country. We are the same everywhere. Oh, wow. So I guess that's the reason why we have the conference today. The barriers is about the time, equipment, staff constraint, no guideline, lack of multidisciplinary communication, patient belief, lack of assessment for the readiness, and lack of duty description. It's happened everywhere, not only in Vietnam. It's not. So we should do something for this thing. And after my survey, I can see that this is ideal. To be healthy, to be independent, to be we need more than a lungs. And our survey showed us we care too much about the secretion. We need the lungs for the ventilation, but we need the circulation to bring the blood to other organs. We need the muscle work well, yeah, and we need 3 components to move equally. They are important equally. But our survey look like this one. We care too much about secretion, very, very little about the circulation, and little about the muscle. So we have to change. Yeah, and I believe that to improve the circulation and muscle, we need active. We need to move the patient. And I don't think that in Vietnam, honestly, frankly, we move the patient enough, in ICU especially. But I have to clear here. I don't say that secretion is not important. I just say secretion management is important, but it's not the only thing. And regardless of the low evidence of the chest therapy, percussion, and vibration, they are not the sustainable to manage the secretion. If you want to break the vicious cycle between the immobilization and the secretion retention, you have to move the patient. And that's, I believe, that we didn't do enough in Vietnam, I think. And evenly for the lungs, for the respiratory, it's not only the lungs. And the lung is not only about the secretion. Yeah. So if we want to have a good respiratory, we need the lungs, of course, but we also need a muscles, respiratory muscle, which is controlled by the nervous system. So therefore, any quickness or dysfunction of the muscle can impair the function of the respiratory system. Yeah, and we have a lot of evidence here to show that if you can train the respiratory muscle, especially the inspiratory muscle, we can increase the function of the lungs, and we can reduce the consequences for the patient in the ICU. And so therefore, I think that we have to have a more comprehensive approach to a complex condition of the patient in ICU. And I think that's applied to all patients, not only in the ICU. Yeah. Yes, so it appears that the ICU rehabilitation in Vietnam is currently lagging behind the recommendations. But however, I think that to criticize or to complain about the system, we need to understand the context, background of the ICU practice in Vietnam. We can see that it's overloaded. We lack of human resources. We lack of many things. And in fact, we lack of data. We lack of the evidence. When I try to compose this presentation and I'm looking for the data for the ICU practice in Vietnam, that's a huge blank. And we need to fill in. Yeah, so to do that, I think we need data, we need the evidence, and we need more research in this area. And that is some suggestion from the participant of my survey. They believe that training and education is important. And the OT and the XT, in my survey, they say that they wish they have the independent professional association. So with the independent association, they can keep up with the development of the world. That's very important for them, they told me. And science research is hugely important. Without data, without the evidence, we don't know where we are, and we don't know which direction we should go. Guidelines and comprehensive regulation for early immunization should be established to encourage the implementation, because sometimes we don't know, okay, what's our duty, if something wrong, what's happened. We need the guideline, we need the regulation. And while waiting for the human resources development, maybe the equipment should be involved to help to reduce the burden of the rehabilitation staff during their practice, and to prevent the occupational risk disease during their work, and so on. Finally, I would like to finish my presentation with 2 take-home messages. First, every move counts. So let's move the patient. Let's get them as active as possible. That's the easy and the cheaper way to do this. And the second one, I think we should care more about the general health before we get into the ICU. So a study of Matthew et al. With the Kaplan-Meier curve show that at the time when you admit the ICU, if you have a better exercise capacity, you have a better chance to survive. So don't wait until we get sick and don't wait until we get into the ICU. We need to be proactive now. And thank you for listening to my presentation. I wish you a great conference ahead with many interesting topics. Thank you.
Thank you very much, Min. It's a very interesting reflection that all across the world, the data is very similar. I will now open to the floor and to the panel here for any questions.
One thing I'll say while we're waiting for the microphone is what Min has, so last night we had a meeting of our Asia Pacific ICU Rehab Committee, and what Min has just described in terms of barriers and challenges and the state of the art, our representative Bala from Singapore told the same story from a resource-rich country maybe 15 years ago. To use Bala's words, sort of ICU rehab was zero in Singapore, and then we had a conference in Singapore and development and things, and now rehab in Singapore is like 100%. So this isn't just only an issue in lower resource settings. This is an issue in Singapore, in Taiwan. Our Taiwan representatives were discussing their challenges. Our Nepalese representative was discussing challenges. So this is an international issue in both resource-rich and lower resource countries. Over.
So kind of a two-part question, especially when it comes to the U.S. This is going to probably, how much does the legal aspect, I think, is this dangerous? Can I move the patients? I'm a huge believer in getting moving early, but then what's the legal risk on top of that? I'm going to set that aside because, we don't have lawyers here, hopefully. Anyway, when it comes to the negative side effects, how much does the medication suppression into the ventilated patient suppressing the neuromuscular activity? So, I don't deal on the pharmaceutical side of things. So, that's a different profession. So I'm not really aware of when you're medicating a patient, because it's all about oxygen delivery. You cannot heal. So how much are you maintaining what's a standard blood pressure that you want to maintain in the ICU? What I see commonly is the blood pressure being too low because they're over medicated. Well, if you're keeping a blood pressure too low, you're not delivering enough oxygen and you have a higher metabolic process trying to heal. So the combination of the medications, whether you're trying to keep the patient in a coma and or keeping the blood pressures modulated to a lower than needed level, how does that factor into the speed of recovery for the tissue, especially when you go vertical? We see vestibular issues, the dizziness, the balance problems. I see that much more related to too low blood pressure versus high blood pressure.
Sure. So I think you've hit two critical issues when we're starting ICU rehabilitation programs. We need to, we can never focus on rehabilitation until we address the issue of sedation. ICU doctors and nurses, to tell them that patients can be awake with an endotracheal tube is like telling them the earth is flat. none of us have trained, unless we trained in the 1960s, none of us have trained to recognize that's usual care. So we do need to address sedation. Sedation has negative effects on the muscle because of immobility, has negative effects on the brain because in critical illness, the blood-brain barrier is not intact. So this isn't like going to an operating room where you can get an operating theater where you can get these medications without as much of a negative impact on the brain. These sedatives now are bathing the brain. And then it has an impact on blood pressure as well. These sedatives decrease people's blood pressure. So that's the first thing to address. We can't use Min and his colleagues' expertise until doctors and nurses allow our patients to be awake. And then the second issue is all of us need to be concerned about safety. If we simply say to a therapist, you need to come and start treating this patient, without thinking about the collaboration and the communication around doctors, nurses, and therapists together, then we will have adverse events. But with a team approach, communication and training, this can be very safe. And I would say that the risks of bed rest are higher than the risks of mobilization in a critically ill patient with training. So thank you for your great question.
Any other questions?
Thank you. My question for
Yes.
Prof. Dale Needham, because my name is Evi and I work in University of Indonesia Hospital, and most of my patient is elderly, because we know that the elderly already have sarcopenic before the hospitalization. And from your speech before, you said that we cannot determine about the dose, about the intensity, and for ICU patient, when we start our mobilization, what is the parameter, and after we start the exercise, what is the parameter to stop? Because I think this is the safety issue. Second one, about nutrition. Should we wait the nutrition first from the doctor, or we just start for exercise? And the third one about the quadricep muscle ultrasound. It's very interesting because we know that the maybe ultrasound quadricep might be a prognosis for outcome for patient in ICU. And is it the standard protocol, or we perform this for special purposes? Thank you.
Great. So I'm going to give the PTs to the right a heads up that I'm going to ask you to respond to the first question around dose in a minute. I'll respond to the second two, because I think so first of all, thank you for coming from Indonesia. We are so happy. We were so proud when our conference happened in Indonesia, and we're glad that you're coming to share your expertise and to meet people in Vietnam.
Thank you.
So I'll do the second two questions. There was a question around nutrition. Everybody's interested in nutrition. The correct answer is we do not know. There are very little data to help us inform the question of nutrition combined with rehabilitation. In fact, this is the #1 research agenda question in the field of critical care nutrition and metabolism. We have phase 2 trials that aren't sufficient to tell us if we should use more protein, if we should use indirect calorimetry to customize nutrition every day. We simply do not know. I gave a disclosure at the beginning of my presentation that we're doing a phase 2 randomized trial of high protein combined with exercise. I'm a principal investigator and I still don't know that answer. And even when my trial is done, it's only a phase 2 trial, so we won't know. So it's a very unsatisfying issue at this stage. I can't tell you that you should use higher protein because there's no evidence for that. So we really don't know. The second question is around ultrasound. We all love ultrasound. It's a visual way to tell us about the structure of muscle and to look for changes. But even in many high resource settings, we do not use this as part of regular clinical care. This is, and I say that because I don't want people to come away and say, the first thing we need to do is buy an ultrasound machine. I don't think that's a good use of resources. It's primarily used in research to help us understand what's happening with the structure of muscle during critical illness and during rehabilitation. In my randomized trial, we are doing longitudinal ultrasounds to see if those that get extra protein and extra exercise have a different change in their muscle. But what we're really interested in is strength and function. And our primary outcome is function, the 6-minute walk test, because that's going to be much more important to patients than what their muscle looks like on ultrasound. So I think it's very useful, but I don't think it's an essential part of clinical practice. And I think I will hand the first question over to Sue or Tom. Or sorry, Sue or Leon.
Here you go.
Okay. For the first question, I will try to answer. Maybe Professor Su can at some point after my sharing. Usually, when we want to start early mobilization or rehab for the critical care patients, we have to do medical risk assessment. We have to make sure patient is stable in terms of cardiovascular, respiratory, and neurology status. And of course, you may have to look at a patient's clinical progress, the improvement, instead of the vital sign alone. You have to look at the patients, and there is no it's essentially a team approach. As a rehab physician, or even as a therapist, you always have to consult the primary team doctors. If it's the ICU doctors, you have to discuss the case, whether mobilization is allowed in the patients. For the second part, talking about the indications to terminate the exercise, when you think the patient develop cardiovascular, respiratory, or new onset of issues, neurology, complication, fever, all those are indication to terminate the exercise. Again, always give the feedback to the intensivist or the primary care doctors so that we can co-manage the patient with a multidisciplinary team.
I would agree with all of those statements. The answer for dose is that we don't know. There isn't sufficient evidence to say that it's 20 minutes of this or it's 15 minutes of that, which is one of the things that's challenging for the ICU rehab community. But I think that to speak to the team approach is very, very important. So the team has to speak to each other so that because often the physical therapists or physiotherapists are not in the unit all of the time to understand what's happening with the patients. So that discussion with the medical and nursing staff is important. And the other thing that I think is important is that there is a protocol that says exactly what it is that we intend to do and when we should stop because it's not safe. And I think those are really important structures to have in place before you start early mobilisation so that there is an accepted view of what the practice is and that practice can change over time and become more expansive as the capability of the group providing early rehabilitation or early mobilisation grows. But it needs to be very clear up front, I think, about when you would stop rehabilitation and when it's safe to start rehabilitation. And that is a protocol and a decision of the multidisciplinary team. And I think that's how you maximise safety. Katz, I don't know if you want to make a comment, or Bala or Tom.
I recommend to the Indonesian clinician when you start the mobilization in your hospital. I recommend making criteria your own hospital. Please discussion with physician and PTOT nurse. Please involved and make the one original safety criteria. Many manuscripts published regarding the criteria for early mobilization. Please refer it and please discuss one original making the criteria. My advice.
Thank you.
Just want to add on to what Professor Bernie has said. Dosage cannot be determined. What I want to say is exercise in ICU is not progressive. Today, I can walk a patient, but tomorrow, I may not be able to walk a patient. I can only do sit out in chair because he's very dynamic. So that is why to determine a dosage for a patient is very difficult. So we go by patient's tolerance, and as mentioned, we have protocols and criteria. We know our safety limits. Okay, within these safety limits, we can function. But again, the patient is going to guide you. So that will be my answer to your question. How do you determine the dosage for a patient? Okay. Tom, you want to add on?
Yeah, I support all of the points so far. They're very excellent ideas to take back to the unit. In terms of dose, the only other thing I would add is considering re-evaluating with each session. I guess kind of building on your point, Bella, is when you provide an intervention, re-evaluate how did it go? Did you achieve your mobility target? And you can look at it two ways. You can either assess tomorrow and see if they can do the same thing, or if they're responding well, you might do a little bit more. If they're not responding as well, you might do a little bit less. So being adaptive in your ability to provide the mobilization to a patient, I think, is important too. But certainly safety first, and then reevaluate and reassess in time. Yeah.
Thank you, everyone. I'm aware of the time. We've already taken some of the morning tea time break, but I think the discussion around how we do early rehab and the safety of early rehabilitation is very important. And I'm sure that both Min and Dale would be very happy to have further discussions during the coffee break. And I would invite everybody to go and have some refreshment, and then, very importantly, the posters after that. So thank you to our speakers, two excellent presentations to get us underway.